Lawrence said he'll go somewhere where there's better connection, but he'll obviously only be able to join towards the end.
Hi guys, we're currently live. Please just give everybody a chance and we'll stay on mute until it starts.
Dear panelists and participants, thank you for joining us. Apologies for the delay in our start. We are ready to go ahead, Program Director, whenever you are ready.
Okay. Hi, me.
There's a bit of a lag on your side, ma'am. It looks like we've lost our Program Director due to a data issue. An apology for that. She'll be joining us again in a minute.
Muted. Hello. Now.
Hi, MJ. Your line is still very bad.
Hey guys, can you hear me?
Yes, we can hear you and we can see you.
Technicalities. Why? I'm not really sure what's happening, but I seem to not be upstairs. Oh, jeez. Don't the internet lo indenza le nto. Sicabanga. I-strong ophiya ezantsi okanye phezulu? Oh, jeez. Baba. Bantuthu ngo. Bantuthu. Oh. Oh. And now is it better? Hi.
Yes, it seems better.
Better now. Oh, wonderful. Okay.
We just need you to share your video again, please, with us.
Okay. I'm just trying to switch off this TV. Sorry guys, I'm at my sister's and I don't know how things work here. I'm just gonna unplug it.
I do not believe we ever need to do another recut of this. You drink water.
Okay, so am I clear now?
Yes, we can hear you very clearly.
Hear me perfectly now. Okay, I'm gonna. Whew. All right, so hello everyone. Sorry for those technical glitches. It's live streaming, I guess. Now that everyone can hear me, let me introduce myself and thank you finally that we have made it to KZN after being in the Eastern Cape and Limpopo. My name is Mary Jane Matsolo. I do advocacy and campaigns for the Healthy Living Alliance. Welcome to our webinar that has been organized by the Rural Health Advocacy and the Healthy Living Alliance. Basically, we want to, we all are hearing the numbers that are going up on a daily, every day on our television, on the people that are succumbing to COVID-19. And the idea behind these webinars is to basically give facts around COVID-19 and its interaction or its relationship with non-communicable diseases. I think the silver lining in this disaster of a pandemic is that it has given us a platform to put the very, very important topic of non-communicable diseases in the limelight, something that hasn't happened prior to COVID-19. And with COVID-19, we are seeing a majority of people that are losing the battle to COVID-19 being the people that are living with existing non-communicable diseases, such as diabetes, hypertension, obesity. And this platform is basically a information sharing platform, very interactive. There is no right or wrong answer. We have sourced out the brainiest of the brains, doctors, dietitians, researchers. These are the people that have all the knowledge and the facts, and we want to make this webinar as interactive as possible. Please ask questions. Please make sure that you note things down, because after all of our three panelists have presented, we will then open up a question and answer session where everyone will have an opportunity to ask whatever question or whatever clarity seeking question, information, mythbusters. That is why we have organized this webinar. It's entirely for those issues, for you to ask all the questions and you to be informed and have the facts and understand what is happening so that you are empowered to make better choices. So without further ado, let me introduce our first speaker, who is, please note that when we are at our question and answer session, just remember to unmute your mic, because a lot of people talk and then we can't hear them on the side because of the mic not being unmuted. So our first speaker is Dr. Mariana Khoza. Dr. Mariana Khoza will be sharing on issues around COVID-19 and the relationship between NCDs what's happening with people with comorbidities and COVID-19. She's a first-year public health medicine registrar from the Department of Community Health. She graduated as a medical doctor in 2015 and completed her internship in KZN. So she's a local, which is good. So she understands the landscape, the community, the culture. So she'll be able to put everything into perspective. So thank you, Dr. Mariana. Please, can you take the floor?
Good morning, everyone. Thank you, Mary Jane, for the introduction, and I hope everybody is good today. I'm just going to check if I'm able to control the screen, and then I'll be able to start. Please just indicate if you're able to hear me as well.
All clear, Mariana.
Thank you very much. All right, so I'm just waiting to be able to control the slides, and then we can start. Okay, I think I'm able to control it. Let's see. Apologies, everyone. There seems to be some technical gremlins joining us today. Sorry, Enrique, I'm not able to control the screen. If you're able to just move to the next slide for me, then I think that might work better. All right. So please have a look at this picture and think about if anything is concerning you. And we'll get back to it at the end of the presentation. Particularly, just look at what the lady is doing to protect her health and what is truly, risking her health in this picture. All right, thank you. Next slide. So this is what we'll be covering in this presentation. COVID-19, the numbers at the moment in South Africa. We'll also be talking about non-communicable diseases, their burden in our country, their risk factors, and where we can actually intervene for these diseases. Next slide, please. So where are we now? I mean, our first case in South Africa was on the 5th of March, and this was after the WHO had announced a pandemic of COVID-19, this new pneumonia, which was initially reported in December in Wuhan, China. And since the 5th of March, we've seen a massive increase in deaths and in cases, especially in the last 2 months. Of interest with KwaZulu-Natal is that you had the first case with the Italian 10 that came back. And initially, KZN was the leading province in terms of the numbers, but over the last few months, Western Cape, Gauteng, and the Eastern Cape have been leading. For the province, the number of deaths are still below 1,000. I think yesterday they had reported about 900 deaths, probably will cross the 1,000 mark by today or tomorrow, but more than a 50% recovery rate. For the country, we are above the 500,000 mark in terms of the total cases. So who's actually dying? Next slide, please. Who's actually dying from COVID-19, which is actually the big question, because initially when it came out, it said that most people just have few symptoms, loss of taste, maybe a bit of snuffles. But with some people, they're on the extreme where they actually, when they get this virus, they get very severe symptoms, they need ICU, and they may even die from the virus. So globally, what we're seeing is that males who are over 50 are at risk of, at higher risk of dying from COVID-19 more than females. But generally, anybody who's over the age of 50 is at higher risk. And this is because older people are usually the people with chronic comorbid conditions, but younger people who also have these chronic comorbid conditions are also higher risk of dying from COVID-19. And these conditions are diabetes, especially uncontrolled diabetes. So people presenting with very high sugars, hypertension, chronic respiratory conditions, coronary heart disease, and obesity. Of note is that young people who are obese are really at risk of getting severe symptoms from COVID-19 and dying. And this is what we're seeing in our country. Next slide, please. So, we've had, as we're almost at, we're quite close to 10,000 deaths in the country. And with Cape Town having majority of the deaths, they've started a study there where they're analyzing the deaths and what underlying conditions people actually have. The people where COVID-19, and I really want to stress that in some people, COVID-19, some people don't even get symptoms. And for some people, it's just the flu. But people who seem to have these non-communicable diseases, which are really lifestyle related diseases, they're getting severe forms of it and they're dying from it. And what we're seeing in South Africa is, again, similar to the global picture, men are 40 times more likely to die of COVID-19 than women. And this has been attributed to some genetic differences between men and women. Women have an extra X chromosome, which has been said to possibly be protective, but they're still doing studies around that. And then very, very worrying, 50% of the deaths that they've seen in Cape Town have been in patients with diabetes. Again, this is mostly patients with uncontrolled diabetes, but diabetes as a disease, whether controlled or not, is still a risk factor for getting more severe disease of COVID-19. But we are seeing that deaths are happening mostly in people with uncontrolled diabetes. 19% with people with hypertension. 12% of deaths are in patients with HIV. And this is, we were very worried with COVID-19 with the increase in deaths that we were seeing in Italy. And we thought, with our population of 7 million people living with HIV, we thought we were going to see very high numbers of deaths because HIV does suppress the immune system. But we're finding that actually, yes, there is an increased risk, but not as much as we thought. The increased risk is still very much with the people that have non-communicable diseases. And then we're seeing 9% with chronic kidney disease. And again, TB, we expected a lot of deaths because of our high rates of TB, but much less than what we expected. So it seems that the lifestyle related diseases are the ones that are really the problem. So I've added the slide, which is from the Medical Research Council here in South Africa, where they were speaking about the deaths that we are seeing now at the moment. So the solid orange line that you're seeing in the graph is the predicted deaths for 2020. So we're expecting between 8,000 to 10,000 deaths per month over this year. And the black line shows the actual deaths that have been happening per month. And what we're seeing is that between May and July, there's been this huge excess of deaths since the 6th of May. They're saying up to 17,090 deaths in excess. And of those 17,000, we know that 8,000 are related to the COVID-19 crisis that we have. But there's this other possible 8,000 that we're not quite sure what to attribute it to. Either it's COVID-19 deaths that we have not confirmed, or people, and this is the other reason that has been proposed, is that people with chronic comorbid conditions, because of the effects that COVID-19 has had with access to medical care and access to medicines, we're having more people dying that don't necessarily have the virus, but are dying from their own chronic medical conditions. Next slide, please. And this includes people who are also undiagnosed. So in the absence of COVID-19, what usually causes deaths in our country? And what we have in our country are these top 4 causes of death that we call the quadruple burden of disease: HIV, AIDS, and TB, especially in the 2000s, before we introduced ARVs. This was a big cause of death in our country. With the introduction of ARVs, this has been much better. Then non-communicable diseases, high maternal and child mortality, and high levels of violence and injury. So those are our big causes of death. Of interest is that non-communicable diseases are the leading cause of death, not just here in South Africa, but globally. Next slide, please. So non-communicable diseases are slowly progressive medical conditions or diseases of long duration. They are non-infectious and non-transmittable, so one person cannot give it to the next person. The thing about them specifically is that they demand long-term care, and their complications result in significant disabilities. And this causes and imposes a continuous burden on the health system, but not the health system alone. And there's a burden on families, on communities as well. So there's a huge economic and social cost that comes with these diseases. And examples of them are, we've already mentioned diabetes and hypertension, and please can we go back to the previous slide? We've mentioned there's also cancer as well, obesity, mental health disorders are also non-communicable diseases. What I want to highlight here from Stats SA is this graph that shows how, with the blue line, those were the infectious diseases that were from 1997 to 2016. You saw there was a climb, and around those years of 2000, 2008, when we were having our AIDS crisis, before our ARVs, those were the biggest causes of deaths in our country. But with the introduction of ARVs, these diseases and the introduction of clean water, these diseases are no longer as big of an impact as now what we're seeing with the yellow line, which is the lifestyle-related, very preventable diseases, causing almost 60% of deaths in the country. Next slide, please. So the NCDs are causing almost 60% of the deaths in the country, and of the 60% of those deaths, 36% are in people before the age of 60 years. And this is very, very worrying, because it means we are losing breadwinners, we're losing people when they're at their prime, and this has huge effects and like a snowball effect, in fact, on generations and the community and the country as a whole. So really, we really need to start talking about the effects of these diseases in our society. And this is just the numbers from Stats SA, also showing how diabetes has climbed from being in 5th position from causes of deaths to 2nd position. And these are really lifestyle related diseases. You see that forms of heart disease are in 3rd place, and then cerebrovascular diseases and hypertensive disorders as well are quite high up there. Very preventable. These are diseases we're getting because of what we're eating, whether we're exercising, whether we're smoking or not, and things like that. TB and other influenzas and pneumonias are still a problem, mostly because of the conditions our people still live in, very crowded, and this just increases the risk, and TB is still a big problem for us. But we have ignored your diabetes and your hypertension, and those have climbed up. Next slide, please. All right, so when we talk about the risk factors for non-communicable diseases, we talk about risk factors that we can change and risk factors that we cannot really change. So the non-modifiable and modifiable. Your non-modifiable risk factors are things like your age, your sex, and your genetics. We can't really do much about them. But the thing about these risk factors is that they contribute very minimally to someone actually getting a non-communicable disease and someone actually getting complications from a non-communicable disease. So one of the more important ones that we care about are your modifiable risk factors. And these risk factors are actually determined by behavioral, societal, and structural factors. And I've given examples of unhealthy diets, number one. All right, so what we're eating is really affecting our bodies and can be what determines if a virus that is just meant to cause a flu kills you or not. Tobacco use, alcohol use, as well as physical inactivity. Those are really important modifiable risk factors that we can change and then change the trajectory of these diseases in our society. As to how behavioral, societal, and structural factors affect these risk factors is, for instance, what you eat is not only determined, we like to think that the choice is 100% yours, but it's also determined by what foods are available at your grocery store. Are they cheaper? What do you see first when you walk in? All these marketing gimmicks that people have put in place. Also the political environment and things like that. So, and which the other speakers will also touch on. So next slide, please. Just to highlight again, unhealthy diets, very, very important. So in public health, what we speak about are different levels of intervention where we can, intervene in terms of when we don't want people to be unhealthy. So if we want to intervene for non-communicable diseases, the best place is at the bottom of the pyramid, which is the primordial prevention, where we target the whole population before they've interacted with risk factors. And this has to do with the policies, the social and economic policies that we put in place. So for instance, with non-communicable diseases, how we'd target people to not become obese so they're at higher risk of getting diabetes and hypertension is that we'd make the healthy choice, the easier choice, by making food such as vegetables and fruits much cheaper to buy and easily accessible. And then primary prevention is when we target risk factors leading to the disease. So for instance, we don't want people to be obese because we've seen that people's intake of sugary drinks are very high, and the sugar content of those drinks is very high. So what we do is that we make those sugary drinks much more expensive. So somebody who chooses to interact with that type of risk factor, we try and make it harder for them to buy something like that. But it's really important that we give people other options, and I'll move to that with the next slide. And then secondary prevention, oh, sorry, I was on the previous slide. And then secondary prevention is when somebody already has very high risk of the disease or has early disease, and we don't want them to have complications from that disease. So for instance, if somebody has obesity or has early stage diabetes, we want to find them early, and we want to kind of target them and start them on treatment very early. And then tertiary prevention would be somebody who already now has, the disease, so they already have diabetes, and now we want to prevent further complications. We don't want them to get a stroke and so on. And unfortunately, in our country, majority of people of the intervention is at tertiary level. We're waiting for patients to come to us in the hospital because they had a stroke, because they had a heart attack, because their sugars are very, very high and things like that. And that's when we find them, and that's when we intervene, which is very, very late. We should be intervening at the primordial level by educating people, getting people to eat the right things way before they get the disease. Next slide, please. And this is the Ottawa Charter from the WHO, and was introduced sometimes in the, I think, 1970s, which speaks about when you want to intervene for a particular disease. So now we see that non-communicable diseases are really important, because not only are they important because of the pathology that they just cause, but because they weaken people's bodies, so that we're now having populations that are unable to fight small viruses anymore, So if we want to target changing that trajectory of non-communicable diseases, then these are the levels that we need to intervene. And they say, yes, you need to develop personal skills, and you do focus on the individual, but there's more to it. You need to strengthen community action through NGOs, schools, and things like that. And then you need to create supportive environments. So I made the example of, it's great to have a policy on making sweetened beverages much more expensive and taxing them, but when someone was shopping for something to drink because they're thirsty, and they see that the Coke or the Sprite is much more expensive, what do you have there that is their alternate option? It must be, one, cheaper, and it must be healthier. So there's no point in just making the Coke more expensive, but there's nothing else to buy. So very important is creating supportive environments. Reorientating health services. I spoke about how at the moment, the way our health services are structured is that we kind of wait for people to get sick and then present to us, and then there's very little that we can do for people. Whereas if we have community healthcare workers who are able to go into the communities that people live in, and they're able to interact with people, are able to weigh people, measure their BMIs, see that, no, this person is obese, let me refer them to a clinic before they get diabetes, so that they can start being educated on how to change their meal plans and things like that. And then the big one is building healthy public policy. Again, this is, targeting the whole population, making sure that the policies that are in place are promoting and protecting people's health. So for instance, and not just in the health space, but even in spaces that are not directly related to health, targeting the food industry, targeting the transport industry, making sure that when roads are built, we have more bicycle cycling lanes and things like that, so that people can stay active and stay healthy. Next slide, please. So I've touched on this by saying that COVID-19 has impacted patients and people, not just in terms of when they get COVID-19, then they're at higher risk, which we've spoken about now, that when they get COVID-19, they're at higher risk of getting severe disease and dying from COVID-19. But there's also been this other, silent pandemic, if you would like to call it that way, that where people are dying, not necessarily infected with COVID-19, but are dying because one, maybe we're not diagnosing their diabetes early enough, and they're not having access to healthcare services because of the lockdown and things that have been put in. Because of the poor communication that has also happened, especially in the early phases of lockdown, where people didn't know if they were feeling sick, should they go to a hospital? They were being told everybody stay at home and things like that. So there's a lot of things that we can improve on. But what COVID-19 has shown is that it's highlighted the gaps in our health system, where people have to go to health facilities to get care. And our only connection with our people is if they come to the hospital. Whereas actually, if we had focused on primary healthcare and we had community healthcare workers way before COVID-19, this wouldn't have been that much of a problem, because there would have been someone with immediate access to where the person lives, so that if the person's run out of medication, somebody already knows, being the community healthcare worker, and can then act as a mediator between health facilities and our patients. Next slide, please. So where to from now? Moving forward, again, I'm really stressing that we need to make the patient the center of the health system. So we really need to start moving away from treating people just waiting for people to get sick, treating them because, they've arrived at our hospital, instead of going to look for them in our communities, finding them before they have the disease, and making sure that we promote their health and protect their health. Again, COVID-19 has highlighted how what is actually more important is what we're eating, how strong our bodies are, because we might not be able to prevent all the COVID-19s that may be coming. We're going to be getting new viruses. We, in fact, have been getting new viruses for a very long time, but some of them we don't even know about. Because they come, they're very, we don't even have any symptoms when they infect our bodies, because our bodies are able to fight them. But because of what we're eating, the high processed foods, high foods and sugars and fats, our bodies are becoming weaker, and even viruses that are just meant to be passing by, just meant to be causing a little flu and moving on, are now causing a significant mortality in the world's population. And so I've put here, moving forward, we need to use patients as ambassadors to motivate other patients. Patients who have non-communicable diseases will always be the best patients to explain to people why it's always better to stay healthy, eat the right things, don't smoke, rather than taking a lot of pills and trying to just go about your day with pain and in pain, or whatever your non-communicable disease, whatever symptoms you have from your non-communicable diseases. And also understanding cultural backgrounds and linking that to health policies, and already using our already existing resources to promote health. So I believe in using our families, the community, partners being churches, societies, NGOs, and the schools. And this is where RAP and HEALER come in promoting, people's health, and especially shining this light on non-communicable diseases. So yes, next slide, please. So moving forward, do you still remember this image? Have you thought of what is concerning about it? And the reason I put it there is because you have this lady who's been told that there's this virus, and she's got a mask on to protect herself from COVID-19. But actually, what gives this COVID-19 virus strength, and what makes it a killer virus, is the foods that she's putting in her mouth. And how much education have we given people so that they know that actually what you eat is what's giving particular viruses, not all, but particular viruses or other infections and other diseases, what is making them potential, what is making them their potential killers. So I thought that this picture was quite ironic, that you want to stay alive, you want to stay healthy, so you put on your mask, but no one has told you about how the food you're eating might just be poisoning you and might just be the core of what's really risking your health. Thank you very, very much. That's the end. Thank you.
Thank you, Dr. Khoza. Siyabonga kakhulu wenkosazana for a very enlightful and articulate presentation. I think I tried to showcase my very limited Zulu in there since we are in KZN. I'd like to take this opportunity before I introduce our next speaker to remind people about the survey. So Angithi, after this webinar, we will be sending each one of our participants a survey that we would like. It won't even take you 5 seconds to complete it about the webinar. And we would like to urge everyone to please complete the survey and send it back to us. It helps us monitor these webinars. So without any further ado, our next speaker is Mama Mphumelele Mthembu. Mama Mphumelele Mthembu is a dietitian. I-dietitian ke asiyayazi ukuthi ngaba abantu bawaziyo ukudla ekufuneka sikudlile that have got far more details. So uMama Mthembu uzositshela banzi. Oh, Sulu Samphiwe, banzi ukuthi how I'm trying here. I'm Xhosa, I'm not Zulu, so I'm trying. Umama Mthembu is the dietitian. She's got over 7 years experience in private practice. She's been doing this diet thing for over 21 years. So she literally knows what she's talking about. Over to you, Mama Mthembu.
Talk about no pressure. Jean-Rick, we can go ahead. Ladies and gentlemen, thank you very much for having me today. I think for me, one of the biggest challenges in South Africa that we have is that our people don't see the relationship between what they eat and the non-communicable diseases. So I thought that it was important that today we start by looking at the KZN stats so that we can see the magnitude of the problem. So in 2016, the South African Medical Journal published that in KZN, there was 12.5% prevalence of diabetes versus the 9.5% national average. In the same year, the same journal published a project called the Phoenix Life Project that was looking for the first time at the Asian Indian community in Phoenix and looking at their eating habits. And they found that what was interesting is the changes that has happened over the 20-year period, where if you just take the top two chronic non-communicable diseases, the hypertension and diabetes, they realized that in 1996, hypertension was sitting at 14% versus the 47.5% that was in 2016. Again, when you look at diabetes, their prevalence for diabetes was sitting at 13% versus the 20.1% in 2016. Now, the Heart and Stroke Foundation, on the other hand, is saying that 80% of heart disease and stroke are actually preventable and can be attributed to lifestyle. And this situation is expected to worsen over the next 20 years. So once thought to be an old age disease, now is affecting the working class. And I think it's most of the people that are on this webinar. Premature deaths are occurring before the age of 60, again, affecting most of the people that are on this webinar. South Africa has the highest rates of high blood pressure, where 1 in 3 people in South Africa are suffering from high blood pressure. What is of concern is that 50% of people with high blood pressure don't even know it because they haven't screened. So at a glance, if you look at an individual level, you will notice, or we can attribute, that the non-communicable diseases are due to unhealthy eating habits, lack of exercise. Our very lifestyle are centered around laziness. I mean, you have a remote to change the TV, you've got a lift to go to the second floor. The smoking, we are raising a generation of young people that are smoking or that are smokers, or therefore it means that we are not going to get rid of this burden, as we know the impact of, or the relationship between smoking and the chronic conditions. Obesity, which is the BMI above 30, stress. When you think our very period that we are living in, where COVID is taking away our loved ones, we are losing jobs, we are actually not sure of what the future holds for us. This is a very stressful environment, which means that further contribution to non-communicable diseases. The high cholesterol and fat levels in the bloodstream, age, and family history. It is interesting that in a study done by Lisa Clare in 2014, where she was looking at the food consumption changes in South Africa between 1994 and 2012, this study indicated a shift towards consumption of high caloric intake, sugar sweetened beverages, increased proportion of processed and packed foods, probably because we are very busy and we don't have time to cook. An increased intake of animal sources, again, the increase in disposable income post-1994, added caloric sweeteners, decreased vegetable consumption. And what they concluded in this study is that these shifts were concerning to public health because of the selected food items that were contributing to high fat, sugar, salt, and total energy intake. Furthermore, the nutrition consequence of these food consumption shifts was associated with increased obesity and non-communicable diseases. So I thought it was important to then look at the role of industry, what is happening in terms of the processing and food production in the South African context. Now, sugar plays a very critical role in terms of most of the processing methods that we need. For an example, in preservation, sugar is used to improve shelf life, fermentation to improve viscosity. If you look at products such as yogurt or sour cream, the bulking and texture of certain products such as your cereals, improving the mouthfeel, the color and flavor, improving appearance, the sweetness that impacts on taste and palatability. What is also of interest is that although there has been argument that sugar is actually not the problem, but what other things people are actually eating. But the challenge is that some of the food products don't actually say sugar, which is what people would expect on the product. But they have words such as maltodextrin, because the sugar is being called by another name, such as maltodextrin. So a person is thinking, well, I'm cutting sugar in my tea. I'm not going to use any sugar, but they are consuming a product that is very high in maltodextrin or syrup or barley malt, thus resulting in the same problem. Addition of sugar to foods that you would have least expect, for an example, the yogurt. The breakfast cereal, the spaghetti sauces. If you look at yogurt in particular, you will notice that the more things are added to your yogurt, the higher the sugar content per 100 gram. For an example, nowadays we have custard flavored yogurt and so many other variations of yogurt. Therefore, the need to actually read the labels to understand what we are buying. The addition of a health claim in a product, like a product is natural, is healthy, is low fat or diet. If we take in particular milk in this particular example, and you look at full cream milk, you compare it to low fat milk, and then you compare it to fat free, what you will realize is that in certain brands, the lower the fat content of the milk, the higher the sugar content. So because when you remove the fat, sometimes the product will lose its palatability, then the addition of the sugar also to preserve that product so that you have a longer shelf life. Lowering portion sizes, for an example, saying that a product like a pizza, saying that it's a mini pizza, make the consumer think that they are eating less of the product or less of the ingredients that are harmful to them, whereas the ingredients haven't changed. It's just that you're eating a smaller portion, but all the salt and other ingredients that might be contributing to fat are actually still in the product. So what is the link between nutrition and non-communicable diseases? It's been well documented that added sugars, refined carbohydrates contribute to overweight and obesity. It's been further documented at length that obesity increases the risk of chronic diseases such as diabetes and hypertension. And fructose can lead to fatty livers. So sometimes even when you don't have a sweet tooth, but you might be consuming a very high sugar content because of not being aware that those products that you love are actually very high in sugar. Therefore, this increased the need to limit the added sugars in an effort to combat the non-communicable diseases. So I thought it was important to look at the sugar and what is happening on the market in terms of the sugar, the fat, as well as the salt, in terms of what the study indicated. How does these ingredients affect us? Sugar is addictive. It creates more craving for sugar, apart from the health problems that we noticed above. Also, we know that sometimes margarine are associated with high sugar consumption. It causes a sugar rush. And then a few minutes later, or 30 minutes or so later, you may find that you are also craving for more sugar. It's also been linked to inflammation, exacerbating some of the already existing conditions. So therefore, there is a need to basically limit the sugar consumption. The fact that our South African population doesn't seem to think that the starch actually turns into sugar once digested, because you will find them saying things like, I wash my rice, thinking that once the rice is washed, then the sugar is reduced. Whereas what you eat as rice is starch, which will then be further digested and giving you sugar, therefore impacting on your sugar levels or in fact impacting on your caloric intake. The increase of refined starches and instant products such as your mash and porridges. And also, if you look at products such as maheu, you'll find that it's now being flavored. So we're taking a product such as maize that is already full of sugar, we're then flavoring it with a banana or flavoring it with pineapple, and therefore increasing the sugar content, the total sugar content of that product. Next slide, Hendrik. The other challenge that is facing, that we have globally, and then as South Africans, we are not immune, is the genetically modification. Not being sure what the impact of genetically modified food is to the population. And these are mainly done to foods that are readily available to the communities that are living below the poverty line, your maize, your sweet potatoes, your potatoes. Therefore, the reason for genetically modification is really to make the crop disease and drought resistant, thus requiring fewer environmental resources such as water and fertilizers, less use of pesticide, improving the food supply, thus reducing the cost and longer shelf life, faster growing plants and animals. Now, our fruits and vegetables are supposed to be our fallback plan. However, now there is an issue of affordability because these two items have become very expensive on the market. If then they are not affordable, that means that they are not accessible. The concern with the use of pesticide in growing these two products, the canning of fruits, which strips the fruits, the fiber which we need to lower or manage the sugars better, or lower or improve the cravings for those people that are trying to manage their weight. And also the canning introduced the sugar in terms of preservation. The canned vegetable also introduces salt in terms of preservation. So it's a catch-22 situation where you don't win. You need the food products, but then again, you're gonna introduce something else. We could say that people must go and buy organic options. However, they come with a price tag. Again, meaning that our people that are living below the poverty line cannot therefore afford the organic options. Now, as South Africans, we are also faced with the challenge of malnutrition. However, the problem is the processed meats are viewed to be a bit cheaper, and you're looking at sausages, your cured meat, your dried meat, your hot dogs. However, these products are linked to heart disease, the additives to preserve them, to improve flavor, the high salt content and other compounds that are added for shelf life, for taste, which are a concern in terms of the health aspect. The alternative options, which are your lean meat, your the single ingredient type of protein sources, the challenge is that they come with a price tag. If you go and buy sugar beans, it's very, very expensive nowadays. Even your Polonis, your Viennas are very, very expensive. So it really leaves our most vulnerable group with nothing as an option because of the price tag of these products. Yet they are very important for muscle building and improving the malnutrition. So what are the take-home messages that I would like to share with you today? That individual behaviors are not independent of industry. We therefore need to educate our communities on the link between the food choices and the non-communicable diseases. We further need to educate our communities on how to read labels to make informed choices. Food must be affordable in order to combat malnutrition and ensure accessibility, particularly to our poorest of the poor that are living below the poverty line. We cannot lose sight of the non-communicable diseases. The monitoring, the treatment, the screening for non-communicable diseases need to continue in the time of COVID, although the shift seems to be more on COVID. But now that we know that there's also a link between the non-communicable disease and COVID, it emphasizes the need to not take the eye off the ball. We need to therefore not ensure that food labeling is regulated, but we need to ensure that it is monitored, that implementation is happening, and that compliance post regulation, that post implementation, that it is happening. It's not just that people are doing their own thing and no one is actually checking whether they are doing what has been regulated. Ladies and gentlemen, we cannot continue to do the same thing and expect a different result. I thank you.
Thank you so much, Mamum Tembo, for that very insightful presentation. Oh, Madoda, I think I'm still stuck at this. You said something around, even if you wash out rice ngamanzi and reduce the amount of starch, you eat it, and at a later stage, it is turned
into sugar, yes.
MJ, you are muted.
Am I muted? Sorry. I'm defeated when it comes to that the rice that we initially thought it was starch is later on turned into sugar. So this thing of food is really more complex than we understand it to be. And at this point, I would like to say to our participant, ningasabiswa sisilungu uJoji lo simkhulumayo ingathi umkhulu kakhulu, and then nisabe participate abantu bakithi. Sikhona la, we can interpret your Zulu on Xhosa and any other ethnic language that you feel comfortable in asking a question in. So the interpreter into English. The most important thing here is that please do not let this opportunity pass you by without having asked and getting as much information as possible. So now, without wasting any more time, let us move on to our next speaker, Umamu Tamarin Jenkins. She is from the Public School of Health in the University of the Western Cape. Did I get that right, Tamarin? Don't see my notes here. I tried to specify that you are from the School of Public Health Works, right?
Yes, School of Public Health.
Wonderful. Take it away.
Great. Okay, so I am just going to be discussing some food policies that can be considered regarding these dietary NCDs that have been discussed at length already. And just to recap, we've heard that overweight and obesity is a big challenge in our country, particularly amongst our women. And unfortunately, the picture doesn't look like it's going to be getting any better. By 2030, we are expected to be ranked 10th in the world for childhood obesity if the current trends continue, with approximately 30% of our children being obese by then. And as Pumulele has very nicely explained, a lot of this problem is because we are consuming so much processed packaged foods that are high in sugar, saturated fat, and salt. And we can see that year on year, South Africans are purchasing more and more of these packaged foods. If we look specifically at snack foods and soft drinks, we can see that, again, every year, the number of these snack foods and cool drinks that we are importing into South Africa is increasing. And this graph shows both South Africa, which is the dark black, and then other countries in the SADC region all combined together in the lighter gray. And so it's very clear to see that South Africa is consuming much more than our neighboring countries. And if we look at one snack food category in particular, our breads, pastry, cakes, and biscuits, then we can see year on year for the last 25 years, we are spending more money every year on these types of foods that are high in these unhealthy saturated fats, salts, and sugar that are leading to our obesity and NCD pandemic. This map over here represents the spread of supermarkets. This is particularly in Cape Town. However, the picture is similar in other cities in South Africa. The green dots represent supermarkets on the left in 2003, and then 10 years later on the right. And we can see that we have had a dramatic increase in the number of supermarkets. And what is important to note is that most of the new supermarkets are found in our lower income areas, which means that the increase of availability of these packaged processed foods is spreading rapidly into our low income areas too. And processed food is becoming more and more of a problem. Our food consumption has shifted dramatically towards eating more and more processed foods and less healthy foods. So seeing the picture of obesity and NCDs in our country, we need to ask, what can we do about this? What can be done to change this? And I think before we even talk about the what, we need to also investigate the why. Mariana already shared this slide. And unfortunately, very often when we come across someone with obesity, the blame is usually put on the person's behavior. They're obese because they're eating too much of the unhealthy food. They're not choosing healthy foods. And it's all about what they need to do to change their health. However, the problem is much, much broader than that. It is not only an individual problem, but it has a lot of upstream factors that include societal and structural issues, and not only individual choices. And the reality of the matter is that even though people may wish in South Africa to make healthy food choices and to change their behavior, healthy food is unaffordable for the majority of South Africans. And if we look at this map over here, we can see that South Africa down here has between 50 and 75% of South Africans who simply cannot afford healthy foods. It is unaffordable for the average South African, which means that no matter how much on an individual level a person may want to choose healthy foods, in our current situation, it's just not a realistic option for most South Africans. And I think that when we consider the food system and the food environment, this becomes even clearer. If we look, there are factors that we perhaps have some personal control over, and then there are other factors that are outside of our personal control that we consider the external domain. So if we look first at the personal domain, things that would influence the foods that we choose would be the accessibility. So for instance, if one has access to a car, they have the luxury of going to the grocery store, buying perhaps cheaper foods in bulk that they don't have to think about walking home to carry. However, if one is walking to the store, you're not going to be purchasing bulk foods that are cheaper. You're going to be purchasing for a day or two. When we think about affordability, what is the food budget? If one has to feed a family of 6 people on a very small budget, that means that fruits and vegetables are simply not going to be on the grocery list because they're unaffordable. Convenience also needs to be considered. So if someone travels an hour and a half to work in the morning and back home in the evening and works a long day, they may only get home at 8 o'clock in the evening. At that point in time, spending an hour preparing a healthy meal is simply not an option. They are going to rather choose a quick, convenient pack of 2-minute noodles because it's just easier and quicker to do. And then, of course, desirability, what one likes in terms of taste, also influences it. But then externally, there are lots of other factors at play that one doesn't have any control over as an individual. And that would be what foods are available in the marketplace. So are supermarkets and stores stocking lots of processed packaged foods, or is it readily available in the stores to buy healthy foods, fruits and vegetables? Then one needs to consider prices. Is the government doing anything to regulate prices to try and make healthy foods more affordable, or unhealthy foods perhaps less affordable? And then in terms of marketing and regulation, this could either be to promote healthy food or to discourage it. If there's no marketing regulation, then you're going to see adverts all over the show encouraging you to buy unhealthy foods. You're going to find that you are encouraged through competitions and giveaways to try and purchase these unhealthy foods. Whereas if the government puts regulations in place, then it may make it more difficult to purchase these unhealthy foods and perhaps easier to purchase healthy foods. So one needs to consider this larger food environment and understand how it interacts and how it's definitely not an individual level choice when we talk about overweight and obesity, but there are much larger structural components at play. And I think the 2015 Lancet series on obesity addressed this very well, where they made recommendations of actions that need to take place to try and change the food environment to make it more healthy. So they recommended restricting marketing to children, regulating the nutritional quality of foods in schools, putting front of pack labels on products, taxing sugary beverages, implementing mass media campaigns, providing financial incentives to improve the food retail environment, encouraging the food industry to reformulate, and including health in all policies. And this needs to be done on a multi-sectoral level. And this picture shows that quite well, that it's not just about health or the Department of Health, but it's very broad structural changes that need to take place at many different levels. The government needs to put policies in place to ensure that there are regulations that promote a healthy food environment. Within the school environment, there need to be policies that encourage healthy foods to be given to the children and that ensure that children learn about healthy foods. On an individual level, and this is where civil society comes in, one needs to put pressure on the government to ensure that they are putting policies in place that create a healthy food environment. And we also need to put pressure on our food producers and our retailers to encourage them to change the types of food that they are selling. And then, of course, it's very important that the government is regulating the food producer and the retailer to ensure that the types of food that they supply are better aligned with good health. And over here we can see that these types of policy recommendations are very much still on the table. This is from the State of Food Security in the World, the 2020 FAO report, and it makes the recommendations that we should focus on affordable diets for all through policies and investment that reduce the cost of nutritious foods. And that would be by avoiding any tax on healthy foods, by fortifying foods, and then also ensuring that there are complementary policies that promote healthy diets, such as taxation of unhealthy foods, regulating of any food marketing and advertisements, regulating the food industry, and also consumer-orientated policies to enhance affordability of healthy diets, such as subsidizing the cost of healthy foods like fruits and vegetables that are otherwise unaffordable. If we bring it a little closer to home, we need to look at what is happening in South Africa. And the Department of Health does have an obesity prevention strategy, although it's due to be updated soon as it's the 2015 to 2020 strategy. And within its mission statement, it does state that we should look at creating an environment that enables and promotes healthy eating. And in particular, if we look at goal 2 of the strategy, the goal is to create an enabling environment that supports the availability and accessibility of healthy food choices in various settings. And there are 3 points highlighted here, which are that there should be norms and standards for sugar and fat content in ultra-processed foods, that there should be some marketing restrictions in terms of advertisements, and that we should look at front of pack labeling. Unfortunately, at this point in time, there are very few regulations that South Africa has actually implemented around this, but the intention to do this is there. I would like to just share the case study of a country that I think has done very well at implementing some regulations to encourage a healthier food environment, and that is Chile. Chile is quite similar to South Africa in that it has a high level of obesity and overweight. It also previously suffered from undernutrition and is now seeing more overnutrition. And like South Africa, it also has a very high intake of packaged foods that is increasing. And so they decided that there were 4 nutrients that needed to be addressed, which were sugar, salt, saturated fat, and energy, because these were the nutrients that were causing a rise in obesity and NCDs. And so regulations needed to be put in place to try and minimize their negative effect. So they came up with 3 regulations, which were a front of pack warning label, restriction of food marketing to children, and restriction to the school food environment. And they implemented this policy, and I must say it took them a long time to get there. They started in 2007. The law was eventually passed in 2012, and the regulation was implemented first in 2016, although it's been phased in over 3 phases, and only last year was this regulation finally officially completely in place. And if we look at what it has done, here you can see an example. This warning label is what is on the front of the pack, and what that would say is high in sugar. And so here is a yogurt which has got a high sugar content, and when you purchase it, you can immediately see that this product is high in sugar. And then there's also a label for high in saturated fats, high in sodium, and high in calories, depending on which product it is. Here's an example of their shelf where all their chips are, and it is very clear to see every single packet of chips in Chile has got a warning label because they are unhealthy foods that are discouraged. In terms of marketing, any food that carries one of these warning labels is not allowed to be marketed to children under the age of 14. So they are not allowed to be advertised during children TV time or in print, and there are also a fair number of restrictions. For instance, if we have a look at this box of cereal, before the regulation came in place, the cereal box was allowed to carry the cartoon logo of Tony the Tiger, and it looked like a very attractive cereal box for kids. And after the regulation, it had warning labels on it, and Tony the Tiger has disappeared. They're also not allowed to be any toys or gifts in these boxes. And so that just discourages children from being attracted to these types of products. Within the school environment, any product that carries a front of pack warning label is not allowed to be sold at the school. It's not allowed to be served in any school lunches. It's also not even allowed to be packed in by the parents into the lunchbox. So children learn from a very young age that it is unhealthy to have these types of food. And I would just like to share some findings from a focus group in Chile, where they interviewed some parents of these children at the schools to find out whether or not these warning labels were working. And I thought that I would share some quotes with you. A mother of a 9-year-old child said, "My son eats at school. He, by his own, started to decide what he can eat and what not. This is because of these black logos that are on the package." And another mother of a 5-year-old said, "Because of this new law, my daughter has been taught a lot about these black logos. No, Mom, you can't buy me that. My teacher won't accept it because it has those labels. And she requests me salads. She doesn't accept snacks that have black labels." And I think that's absolutely amazing that a 5-year-old is able to identify that. And just lastly, these logos, they help you a lot, because sometimes there are things you wouldn't even imagine that they had so much sugar. One thing is knowing that it is sweet, and another is knowing how much sugar it has. I think it is a good measure because they kind of reveal the reality of the product you are buying. So I think it's important that we learn from other countries and try to advocate to encourage that South Africa implements similar policies to try and protect the health of our population. Thank you very much.
Thank you so much, Tamron. That was very informative and enlightening. I think one thing that we really need to take away from your presentation is the fact that it's very hard to maintain a healthy diet when the environment is not enabling, and everything that is pushed to you and is available on the shelves basically is processed and high in sugar content and salt. So thank you very much for that. That was really insightful. So now I would like to open up the floor for our question and answer session. And we've been receiving a steady stream of questions. I'm going to read out the first one, a question that was sent on our Zoom that says, for someone that has not yet been contracted TB and has no history of TB in their family bloodline, how much of a risk does smoking on a regular pose in their vulnerability to contracting COVID-19? I think that one is for you, Dr. Khoza.
All right, hi. So let me just start my video. Thank you for the question. So in terms of the risk of contracting COVID-19, I just want to remind us that there's a difference between the risk of contracting COVID-19 and also the risk of developing symptoms and developing severe symptoms and dying from COVID-19. So in terms of the risk of contracting COVID-19, that doesn't seem to be increased in smokers, unless maybe if they were sharing smokes or something like that, then it would be increased if they're not social distancing. But we all, if we don't follow the social distancing rules and we don't wear our masks, we're all at almost the same level of risk of contracting it, especially because it's such a contagious disease. Where the difference comes in is once you have the disease or you've been exposed to that disease, what are the risks of you developing symptoms or developing very severe symptoms? And so there's been studies, there hasn't been quite direct proof, and the smoking industry is really fighting this so that they can lift the ban on cigarette smoking. But there's just been a few preliminary studies that have shown that people who do smoke are having more severe symptoms of COVID-19, but there hasn't been very great evidence at the moment. What we do know, though, with any disease that affects the lung, if you have some sort of underlying lung pathology, which you would have if you're a smoker and you've been smoking, especially chronically, you would have some sort of damage to your lungs. What we do know with regards to that is then that you are probably, if you do get COVID-19, at a higher risk of getting severe symptoms and possibly needing ICU or maybe even dying from COVID-19. So I just want us to remember that contracting a disease is very different from how your body responds to that disease. So the risk of contracting, I don't think is increased if you're smoking, but the risk of having more severe symptoms is probably increased. Thank you very much.
Hi, everyone. Cassandra Jagesa here from the Rural Health Advocacy Project. I hope you can all hear me well. I'll just be assisting Mary Jane with the questions. So we do actually have another question from Sanele, which was posed to Dr. Mthembu. So Sanele wants to know, what do we mean by sugars called by other names? Would this be artificial sugar, and does this have the same harms? And then, for example, zero sugar tonic was deemed as clean by the dietitian, but does this contain sugar that's harmful as well?
Cassandra, I didn't get that last part, but to answer the first part that talks about sugar being called by other names. So let's say you are looking at a beverage. One of the ways you can read the label is that one, you can either look at the nutrition content where you're looking at the grammage of the sugar, where it's written total sugar per serving. The other option is, if you don't understand how that information is presented, you can then look at the list of ingredients. It's written in a descending order, starting with the most high ingredient. So that is where the changes have happened. So instead of using sugar, if the list is written in a descending order, you know that if your label says water, sugar, and then it's got other ingredients, it means that your sugar is the second high ingredient in that product. So some products won't have sugar. They will say water and they will say maltodextrin. Now the consumer is thinking, oh, well, at least this product doesn't have a lot of sugar, so therefore maybe I can change to that instead of using the one that has got sugar in it. So there is a need to educate people that any word ending with OSE in the food products, it usually refers to the sugar. Your glucose, your fructose is referring to the sugar. Your dextrose is referring to the sugar, but also the other names that are used, like your syrup, are also referring to the sugar. Sometimes you find that there is sugar, there is also syrup in the same product. So again, that makes you see now that I've got sugar sitting at number 2, but I also have syrup sitting at number 3 or 4. Therefore, it means that I'm really consuming a high sugar content, even though you don't understand what the grammage means. If you can repeat the second part for me, I didn't get it at all.
Yes, sure. So Sanele actually just gave an example. So zero sugar tonic was deemed as clean by the dietitian. So they just want to know, does this contain sugar that is harmful as well?
The zero sugars, the zero drinks.
Zero sugar tonic, yes.
All right, okay. So there has been, I was looking at it, and there's been no scientific evidence to really say that the sweeteners, because that's what we are talking about, the sweeteners that are added and that are added into food products are actually harmful. So there has been studies disputing the relationship between sweeteners and cancer, sweeteners and erectile dysfunction, because there were so many claims that people were coming up with. However, there has been a link between the high consumption, the sugar, the sweeteners, sorry, leading to craving for more sugar. So there you are diabetic, you are consuming a lot of sweeteners or sweetener containing drinks and using sweeteners in your as a substitute for sugar, you might end up craving for cake. So it creates a vicious cycle, which is why in my practice, I don't necessarily say people mustn't use sweeteners, but because I'm trying to think which one is a better evil. Is it better for someone to then go and use sugar and say, oh, well, they're saying I can't use sugar, I can't use sweeteners, and I can't take my tea without anything. So what I will do is I will allow them to have the sweetener, but I will tell them that it is not advisable to have high consumption of the sweeteners. So if you're drinking tea 5-6 times a day, I will ask you maybe to use one sweetener or cut down the consumption of the tea so that you're not using too much of the sweeteners, because you will be getting it from the tea. You will also be getting it from, if you're using porridge, you're using the sachets and all of that. Just cut it down a little bit so that you don't have this vicious cycle that I've mentioned.
Thank you for that, Pumulele. Tamrin Jenkins would just like to comment as well on the artificial sugars. You can go ahead, Tamrin.
Thanks. Quite extensive research recently on artificial sweeteners, and the literature is very polarizing. Some of it says yes, it's safe, and others says no, it's not. When one digs into it a little bit deeper, unfortunately, what becomes clearer is that a lot of the studies that are saying it's safe and it's fine to use are studies that have been funded by the food industry. And studies that are not funded by the food industry seem to be saying we need to be cautious about it. There have been a number of large longitudinal studies with very, very high numbers of participants that are showing that these artificial or non-sugar sweeteners, whatever you want to call them, are in fact linked to diabetes and heart disease. So it seems like they are unfortunately not as safe as previously thought. And the other, if one looks at recommendations that are being made, a number of bodies recently are recommending that we shouldn't be including these artificial sweeteners in our children's diets. And so there's definitely cause for caution. And if I can just comment on South Africa, and this is unpublished data, we haven't published it yet, but we've been looking at the content of sugar in beverages since the health promotion levy, the sugary beverage tax, was implemented. And unfortunately, what we are seeing is that although there's a reduction in sugar content, there's been an increase in these artificial sweeteners. And that is not actually what we're wanting. We're wanting a move away from these packaged, processed, unhealthy foods towards healthier options like drinking water, for instance. And so we do need to tread with caution when it comes to sweeteners. And it looks, the evidence appears to be indicating that they are not particularly healthy.
Thank you for that, Tamrin. While I still have you, I've got two more questions for you, Tamrin. One is from Peter Jobert, and he says, how can or how could we put pressure on our government as an individual to increase the rate at which they could roll out these types of food policies? That's the question one. And the second one from Tash Dada is, from the 2015 Lancet series recommendations to address obesity, how successful has the mass media campaigns been so far?
So in terms, and I'm going to say for both of those, I'm probably not the expert. There are better people in these to answer than me. But in terms of putting pressure on government, it's crucial. And I think, that's exactly why we're having a webinar like this, and why organizations like HEALA exist, to try and encourage. And I think it's important that we don't just do it individually, but that we work together. Alone, our voices don't mean much, but we really need to join forces and combine together, and together put pressure on government to demand that we want these types of policies and that they are necessary for our health. So yeah, absolutely, it's something that's very important. In terms of the mass media campaigns, Luyanda, I know, is on the call, and I'm just wondering if she might want to answer it instead of me. If she, I'm just checking.
Hi, thanks, Tamrin. Hi, MJ. Can you all hear me?
Great.
We hear you.
Okay, thank you for that question. So I think it's an important question because it's highlighting the fact that we need communications to help us get to the goal that we want to get to in terms of policy change. And there are several things that communication can do. On the one hand, communication is important for helping to educate people and raise awareness, to help people know what they should be consuming and how they can get better information about the food they eat. But like the previous panelists have mentioned, it's not only up to people's individual choice, and we have to think about how we can use communications to help us advocate for a change, a massive change in the food environment, so that people have laws or policies that protect them by making sure that they've got better access to healthier food, and that they also have better information that warns them about food that is unhealthy. So communications is important. And while the Advocacy Coalition is running various campaigns to help us get to that goal of raising awareness and also advocating, government has a very important role to also, run national communication campaigns like they've done for massive health issues like HIV, maternal and child health, and, sort of cancer awareness initiatives. So it's the role of several stakeholders working, and committed to finding or reaching a point where we've changed the trajectory of the health issue, but also government has a role to play, in investing real resources to making sure that people who are constituents of government have the information they need to make healthier choices when the policies are actually implemented. So it's a multi-pronged strategy, but I think that you're absolutely right. Media campaigns are very important. Thank you.
Thank you so much, Lou. You always manage to articulate these issues to the T. Thank you very much for that. I see we have one hand from Sandile. Sandile, the floor is yours. Please remember to unmute your mic so that we can hear you.
Thank you, Madam Chairperson. Thank you to all the speakers. But my question would be the short one. Let me start with the lady who said in terms of campaigning and putting pressure on the government in terms of the OMG food or artificial food. But my question will be: there is any legislative piece where we can work on, and on the other side, and how can we collaborate the farming industry, more especially the commercial farming, because they are the one who are mostly affected when it comes to artificial food, and also they are one who also more pressured, So, but I think that's the first step. We need to engage more on the farming industry, and the second part, Mamulapa, Mamtembu. Thanks for enlightening us in terms of other diseases, just like the diabetic. But to be honest, in the communities, more especially in the rural areas, diabetic and cardiovascular diseases are not diseases that are regarded as a normal disease, but we normally regard them as an orphan disease because there are less education when we are talking about cardiovascular disease, and those diseases are regarded as the allied diseases because they are too scientific to explain on that regard. But to the first speaker, Usisu Umakosa lapha, I truly agree with you. We are sitting in the space where we are sitting right now due to the issues of COVID-19. But mine will be: we shouldn't go to the effect, but we need to go back to the positive, because right now we are in the situation where we are in right now. But the bigger issue, the health system is falling apart. It's just a question of KwaZulu-Natal or the South Africa as a whole, or you can mention the Western Cape. That are we ready or not to fight against the COVID-19 on our health system? I think that we, as much as we need to educate more and do lots of campaign, but not to forget the issue of reviving the health system, not doing the same mistake that we have done for the past decade, where we are advocating for accessibility of the ARVs and forgetting the health system strengthening. Thank you.
Thank you so much, Babu Sandile, for all of that. I think if I can just jump into that one personally, to try and contextualize, I think Sibamnyama and as Black people, food is very much centered in our cultural practices. We've got funerals, food, we cook a lot, we've got weddings, big weddings, we've got ceremonies. And I think it's very important for us to start, just like we did with HIV and AIDS when Nasandile, we unpacked the problem and we did a whole lot of treatment literacy behind how you respond, how you prevent, how you treat, and it got the conversations going and starting, and people knew how to live and manage and prevent themselves from contracting HIV. It's exactly the same thing that needs to happen with NCDs. And I agree with you fully, 110%, when you say that in our communities, diseases such as diabetes and hypertension are not necessarily taken seriously. And those are the diseases that are affecting our people the most, and our people are succumbing to them the most. And it's about time now that we start putting the issue of NCDs in the forefront, as big and as aggressive and as loud as we did when we were talking and trying to tackle the issue of HIV and AIDS, and really connecting the dots that this is fully related to the type of food that we consume. And also with that is that it's not only on you and not the consumer's responsibility alone if the environment is not enabling, and start really building a mass movement, because we all know how our government responds. If there is not a mass movement, a big enough voice that raises and pushes for policies that actually protect us and make sure that we've got warning labels in our packaged foods, things that when we go to the pharmacy, when you do purchase, at least you purchase knowing that the bigger forces behind the government, the policies have done everything in their powers that they could have to protect you, in ensuring that whatever lands on the shelves is something that has been regulated, is something that is not harmful to you, is something that is not going to land you alternatively seated at a clinic and you being diagnosed with hypertension and diabetes. And the conversation needs to start now, and the lobbying needs to start now, and now more than ever, with the introduction of COVID-19, we have also a unique opportunity to put NCDs on the map and to push for these policies and to make sure that government responds and listens to us in the same manner, in the same aggression, in the same loud, united voice that we did in addressing HIV and AIDS. So I've got one more question that I don't want us to leave out. And that is a question from, let me just try and find it. From a Mr. Yes, in terms, it's a private question which says, in terms of hypertension and deaths, do we need to look out for certain types of hypertension, or is it all types of hypertension? I'll leave that to the floor. I don't want to mention names on who can get on top of answering that. Panelists.
Hi, Mary Jane. I think in terms, I'm not sure if the person asking, okay. So Mary Jane, I'm not sure if the person asking the question is asking with regards to in terms of hypertension and the deaths that are reported by Stats SA, or in terms of hypertension and the deaths that have been reported with regards to COVID-19. But I'm I know that from the study that was done in Cape Town, they haven't differentiated. They haven't like zoned in on the different types of hypertension. It's just from the basic, my assumption would be that it's just from the basic definition of what hypertension is. And those are the patients that then either who were unknown hypertensives or patients who are already on treatment for hypertension. That would be in relation to COVID-19, and in relation to Stats SA, I think it's similar as well. I think I personally might not understand the full meaning of the question. So maybe the person might want to elaborate, or one of the other panelists can also try to answer. Thank you.
Thank you, Doctor. I think it was a general question, not necessarily specific to the stats. Unfortunately, that question came in privately and there's no way of asking. So, Cassandra, do you want to take the last question before we go on and wrap up the session? Do you have one last question for me?
Yes. Okay, so we have one more question, which was from the Facebook Live. So it is to Phumelele. So it says, in your opinion, which interventions and at what level would you prioritize to improve public's nutrition in relation to NCDs? Phumelele, do you get me?
Cassandra, can you please repeat the question for me?
Okay, so it's from Tash Dada on Facebook. And the question is, in your opinion, which intervention or interventions at what level would you prioritize to improve the public's nutrition in relation to NCDs?
I think that as nutritionists, dietitians, we're not active enough in terms of increasing the awareness that is needed. Not just us, even I don't think that enough efforts are done if you look at where people are spending most of their time. So to answer the question, I think that we need to do more in terms of the social media. We're not doing enough. We need to do more in terms of radios. We need to do more in terms of television, so that people start to notice the impact that how they can protect themselves in terms of preventing these non-communicable diseases before they even occur, rather than wait until diagnosed and then manage them. But I think we can actually achieve more results if we help those that already have diabetes in terms of more awareness, manage the chronic conditions, because when they do, then they will prevent the complications associated with the non-communicable diseases, which will also ease the burden on the health system and also prevent unnecessary deaths, as well as those that don't have yet, to make sure that we are preventing them before it actually starts.
Thank you for that, Phumelele. MJ, over to you.
Thank you, Phumelele. Thank you, Cassandra. I think we've covered all the questions that have come from all our social media platforms, from our YouTube, Facebook, and our Zoom. Thank you very much for all the questions. Thank you to the panelists.
Sorry, MJ.
Yes?
Sorry to interrupt. A question just came in.
Oh, okay.
From Lungile Gamere. So it says, is there anything currently being done to regulate the more informal food industries, such as township fat cakes, bars or shops? So I'll just leave that open to the floor if anyone wants to tackle that one.
Perhaps I can just comment here that no, not that I'm aware of. However, the problem with this is that our small shops are really not our biggest concerns. It's the big supermarkets that have the majority of the market share, that are not regulated, that are causing the biggest harms. I think that we need to start where the most damage is being done, and the most damage is being done by our big food retailers who own about 80% of the market share in South Africa. And so before we start going after the very small, shops that are run by one person and feed that one person's family, we do need to first focus on the bigger issue. Absolutely, we do want to try and create an environment where we can encourage and promote and support more healthy food vendors in neighborhoods, so that there isn't just the option of only buying a fat cake on the side of the road, but that we can rather perhaps have the option of purchasing a healthy sandwich for the same price. But a lot needs to change structurally before we can get to that point. I don't know if anyone else wants to comment.
Thank you, Tamron. I'm not sure anyone else is going to comment. MJ, I think you can continue. Thank you.
Sorry. All right. Thank you for that, Cassandra. Thank you for the participation. It was really robust. Before we wrap up, I'd like now to give to Mr. Russell from Rural Health Advocacy, just to connect the dots and give us like an overview and a departing shot and wrapping up this webinar. Over to you, Mr. Russell.
Good afternoon, everybody. Firstly, thank you very much for taking the time to join us in this webinar today. Thank you to our experts and panelists who provided a very good overview of some of the challenges that we face in confronting probably one of the biggest challenges of our time. Our health system is currently facing a significant challenge, as we are in society at large, where we're all going through a whole process of changing our behaviors. And many of us will know that changing social norms is not an easy thing. Similarly, when it comes to things like food and non-communicable diseases, these have often been considered purely at the individual level and not necessarily on the community level. So as civil society organizations, despite non-communicable diseases collectively outpacing deaths from HIV and TB in recent years, we haven't placed much attention on it because we've always considered these things of diseases of lifestyle, and in some ways we've neglected looking at the broader food and health environment that can deliver the kind of healthy lives that we want. But out of this, with COVID, one of the perverse opportunities about it is that put non-communicable diseases in the front line. As we see this pandemic beginning to transmit within our communities, in KZN in particular in recent weeks, some of the harsh realities of not responding to this we will need to confront. But we have an opportunity to act. Currently we have a set of health system proposals on the table, that looks to reform the health system away from its current curative angle towards more health promotive primary healthcare approaches. And it's within those approaches that it's important for us and our civil society partners to lead the charge. I'm sorry, I'm just consulting to my notes. But as civil society organizations, reorientating a system is not something that is new to us. I think our comrades in KZN have led the charge on this. Who would have thought that in 2002, as we were fighting AIDS denialism, that we would eventually defeat that denialism and today have one of the largest HIV treatment programs in the world, even as we still struggle to deal with primary prevention. But the skills that we've developed over the years in confronting that particular pandemic risk can stand us to good use. Mary Jane spoke about our Each One Teach One campaigns during the early days of the HIV response, where we spoke about treatment literacy, where we had peer-to-peer education, when many of the experts told us that, no, this disease is too complicated, taking the medicines too complicated, people won't comply. But we proved that wrong. It's also an opportunity for us to expand the scope of our organizations away from single issue HIV type advocacy to broader health system advocacy. And I think this is where WHEELer and RAP will be looking to work with all of you in the year ahead around how do we build a comprehensive response to non-communicable diseases that, one, includes primary prevention so that people are aware of the type of modifiable changes they can make to their behavior. From a health systems response, how do we ensure that the millions of people living with diabetes but currently not on treatment can access the treatment that they need? And more on a system level, how do we ensure that the kind of food policies, not just in terms of the policies that regulate our industry, but also how do we ensure that programs within our, what do we call it? I keep forgetting, social development departments with food aid and that kind of thing also comply with good nutritious content, particularly working harder towards advancing the right to food and safe and healthy food for that matter. So as we start reflecting on a lot of the learnings that we've achieved today, I ask on you to really engage with us and start this conversation of how we can build a collective community response to ensure that 10 years from now, the kind of disease burden that we currently experiencing has been completely transformed. Thank you again for your time, and thank you to the panelists, and we look forward to engaging with you over the next few months and years as we start building a comprehensive community-driven response to NCDs. Thank you.
Thank you so much, Mr. Russell, for those great parting words. Thank you, everyone, for participating. This has been really a very good, interactive, and robust webinar. I would like to take this opportunity to just thank you and remind everyone that the survey has already been sent to you already. So as soon as you log off from this webinar, it should be in your emails. Please fill it in. It won't even take you 5 seconds. We really would appreciate the feedback. Otherwise, with that, we look forward to many more webinars such as this one. This one was a really good first one, and it's certainly not the last one. Thank you very much. Make sure you stay safe. Look after yourself, look after your loved ones, and just, protect yourself and your loved ones. Thank you very much for everything, and goodbye.
Wow, well done, everybody. I think this was a really good webinar.